as I was saying, and I apologize for getting cut off. I never know where I'm at with my time with these videos. What really is awesome to use, and this is called, again, the CPT like lay descriptions, the coder's desk reference. Okay, the CDR, or the coder's desk reference. And this is a resource out there for you. Like I said, when I was coding, I coded from the book, not an encoder. And so it was another book that I had. But in times where it was like this, is this like the neti pot? Is this lavage? Like how deep, is this, or how in depth do I need to go? You can simply go into the coder's desk reference and find the lay descriptions. And sometimes if you can compare this paragraph and what you read in this paragraph with your note, it can really help you find your actual code description and the code that you should be using. So this is a sweet reference. Again, it is imported or included in our encoder, in our 3M encoder, which we use in advanced ICD-10 and advanced CPT as well. It's important for you to learn how to use the book first, and rules and regulations and things like that, and then we can use the encoder and 3M. So this is kind of a nice tool, and I just want you to know that it is out there, and I use it kind of sometimes to compare those two codes for something as easy as a washing and flushing, or something that's a little more in depth as well. So if we go on, we're looking at the larynx and any codes from that section. Introduction, they talk about intubation. Introduction, they talk about incision here on the next page into the trachea and bronchi. Tracheostomy really is the most common procedure reported with codes from the incision type category. It can be planned or it can be performed as an emergent type situation. We need to make sure we know the difference because that is in the code selection. We really skip everything on the next page and get right to let's see, incision, excision, and removal on that page. With incision, we talk about a thoracotomy, making a surgical incision into the chest wall, opening that area up so that the surgeon can view it. It's a major surgical procedure during which the patient is under general anesthesia. Of course, the codes are divided according to the reason of the procedure, like is it biopsy, is it to control bleeding, is it cyst removal, foreign body removal, all that kind of stuff. Excision, we talk about biopsy here. That last paragraph under excision is kind of important and interesting. Percutaneous needle, lung, or mediastinum biopsy is often performed under radiologic guidance, so we can make sure that we have the needle in the correct place. As with bronchoscopy or bronchography, a procedure described earlier, in the discussion of the trachea and the bronchi subheading, if radiologic guidance is actually used, you report the service with a code from the radiology section. It starts with a 7. There is a note following this code, the biopsy code 32405. It directs you to the surgery section, general, the codes that start with the 1 there in that range. When a fine needle aspiration biopsy is performed, because it differs from a tissue biopsy. A fine needle aspiration biopsy is a procedure in where we remove or withdraw fluid for examination. So we need to make sure we pay attention to that. Maybe make a note there in the book as well. With removal, I think the biggest deal, and I remember talking about it in med-term class too, lobectomies. How much of that lung is really getting removed? Really is what it comes down to with our code selection. First of all, under removal, they say pneumocentesis is the withdrawal of fluid from your lung by means of aspirating a needle again. Air or gas in the pleural cavity is known as a pneumothorax. It occurs when your lung could be traumatically ruptured, or an emphysematous bulla might rupture as well. When the thoracic cavity air pressure increases, that pressure on the lung can result in the collapse of the lung. The surgeon withdraws the air to allow that lung then to reinflate and work purposefully. The codes for the removal of the lung up on the next page are based on how much, again, is being removed. A segmentectomy is just one segment. A lobectomy is one whole lobe. Remember, it's divided, okay, 2 and 3. A bilobectomy for 2 lobes, and a total pneumonectomy for an entire lung, as well as the extent of the procedure and the approach. Those all go into the coding decisions. So be careful when we know, when we are coding those, how much of the lung is being removed. If it says, you know, that we're removing the lung, we don't just automatically assume, you know, what happens with that. Thoracentesis is talking about here. They have the patient there down below that talks about how you sit and how it goes between the ribs there. The preferred method, okay, has the patient in that position. It can be performed to, you know, withdraw fluid for some of the reasons that they list here, or inserting, you know, a chest tube as well. And they talk about how they do that. And really, that's like the end. On the last page of the chapter here, we have surgical collapse therapy or thoracoplasty. That's a procedure, it says, in which a portion of your internal skeletal support is removed to treat a condition in which pus will chronically collect in the chest cavity. The procedure is major. It requires extensive resecting of that membrane that lines our chest cavity as well. Gauze is left in there after several days, you know, and then can be removed. They talk about 32905 as being our code there. It refers to all stages as well. And then they talk about pneumolysis, and then also the pneumothorax injection. So making sure you pay attention to read through this chapter on your own, because I never have enough time to go through it with making these short 15-minute videos. And then again, as soon as I'm done, I will put videos out there for you to watch, the YouTube videos on the neti pot, which is super interesting. Let me know if you have any questions.